Make sure that everybody's got a chance to sign in. Everybody has a copy of the agenda if you would like one.
Oh, is that over there too?
Yeah, I'll grab you one. You want one too?
Can I get one?
Yeah.
Sorry.
Nope, you're all good. And then we'll get started in just a second.
I'll be right back.
Yeah.
Sure.
Cool.
Yeah.
That's yeah. Thank you. Water up there. Yeah, that makes sense. There's no like data behind like elevation and the house that we're doing. You know, oh yeah.
Bringing in reinforcement.
Yeah.
Meeting, so.
Yeah. Yeah.
You don't have a lung condition. So
Yeah, it's not particularly a couple minutes just to like feel like no, like there's a 30 months of it's achievement. Or is it
What's the topic?
And
about
air full time and
Air
I
time.
want to say
Somebody who that's
an hour of the plan is for us all. Or something.
I'll be on the
Yeah.
social media.
Maybe that was-
That's kind of So just my name and contact. Perfect. Yeah, and so it's an email, reminder. So I do. And then there's the YouTube channel is telling me that too. There's going to be lots of presentations, so that's sort of important. Set it there, so you can watch the presentations if you want to go back, if you can forward and that, you know, this, the night after. You have to do it, you can make it, the wall, computer again. But I email. Pizza info. I didn't.
Yes, I did. Yes, she is. Amanda. Did you start recording? Yes, I have.
Hi, everybody.
Jessica.
Hi. We're ready to get started today. So I want to thank you all for coming to this month's Better Breathers Club. Better Breathers Club is run through the American Lung Association, and it's our opportunity to get educated about our lungs. It's open to anybody. So you don't have to be a patient here at UC Health. You don't have to be someone who has a lung condition. You can be a caregiver. You can just want to learn more about how to breathe better. It's just open to anyone. So we're trying to share the word, have more folks from our community come out and learn. So we're going to have introductions. And since I'm up here, I'll start with me. I'm Jessica. I am a patient here at UC Health. I've been coming to Better Breathers Club for almost 2 years now, and I have severe asthma. So sometimes you'll find the topics directly apply to you, your health condition, a loved one, something you're interested in. Sometimes it's just fun to learn something new. We are recording today's session, so it'll be on the YouTube channel. If you want to go back and watch it, if you have to leave early, if you missed anything, if you just want to hear all of this all over again, those will be options for all of you. So we're going to go around the room because we have some new members, and we'll say hello, share whatever you would like about yourself, why you're here today, and then we will go into today's meeting. We have Matt, who's going to talk to us about the lung valve procedure. Jamie is going to chat more about home rehab here, and I will sit down and you guys can get out y'all's way. But first, let's all say hi. So Maxie, can we start with you? Want to introduce yourself to everyone?
My name is Patsy, and I come here Tuesdays and Thursdays for the rehab program. It's awesome. And they told us last week about the meeting, and I wanted to sit in and see what it's all about.
Very good. Thank you. Hi.
Hi, I'm Sharon. I'm kind of a lightweight in the group. I have mild COPD, but I'm a big supporter of support groups and I like learning.
Very good. Thank you, Sharon. You want us to skip you?
Well, you could skip me.
Okay, we'll come back to her later. Okay, you're gonna be.
Hi, I'm Celeste, and I was in the rehab classes in 21. So I've been coming periodically because I get the emails still, and I come periodically, but I have severe COPD, emphysema, and hypoxic.
Thank you. Alex, you want to go or Doc, you want to go? Where's Mike? Doc?
I'm Doc Davis, and I had the procedure done in 2024. I put forward balance in the right lung, and it was a game changer for me because I went from 6 to 4 liters and started pushing it down since I exercise all the time. So I recommend anybody and everybody do that. Oh, so that's a story in a nutshell.
And sorry, I failed to mention after Matt finishes, Doc is going to share his story with us and give us a patient testimony about the success of this procedure. So super glad you're here too. Thank you. Okay.
I'm Dodie. I'm Doc's wife and it just belonged to.
Right.
Right, right.
I'm Alec. I'm a nurse. Thanks, guys, for coming on.
I'm Ruth and I graduated pulmonary rehab class a couple of weeks ago. I have COPD.
Thank you.
My name is Megan. I'm a nurse. I'm actually quite new to my role, but work for Dr. Parrish, who does this procedure.
Thank you.
I'm Reggie Ackermeyer. I have asthma, COPD, interstitial lung disease, pulmonary hypertension. I come to maintenance. I've been coming since 2018.
Thank you, Regina.
Steve had double lung transplant 5.5 years ago, and also had a hangnail.
Take care. Thanks for sharing that.
Awesome.
Thank you.
Double lung transplant in 2012. So September will make 14 years for me. I come to maintenance program for pulmonary rehab Monday, Wednesday mornings at 7. But try to make it as many days as possible. And I've been coming to pulmonary rehab since 2011.
My name is Greg. I just started my pulmonary rehab. And actually, it's been when you have about the valve.
Thank you.
I'm Dean Hutto, interstitial lung disease. Received the gift of life via double lung transplant back in 2014, and September will be 12 years.
Wow.
Right.
So
I'm opposed to, I have interstitial lung disease and pulmonary artery hypertension with CTIV. And it will be 3 weeks since I had surgery for the CTIV. And I walked out of the hospital with no oxygen.
Thank you, Phyllis.
I'm Margaret Bates and I have COPD emphysema. And I've been coming to pulmonary rehab, but I'm currently doing the maintenance programs on Monday and Wednesday.
And what else are you doing?
What's that? Oh, harmonica. Yes, we're very few of us today, but there's usually a lot of us here, and it's a great way to get support as well as just socialize and learn how to play the harmonica, which is surprisingly easy.
Awesome. That's Tuesdays, 11:30 to 12:30?
11 to 12.
11 to 12. Okay. Public service announcement.
Yeah, PSA.
Tuesdays, 11 to 12.
7 o'clock.
Did any of the staff want to say hi? I catch Amanda full. Thanks, Brian.
I'm Laura. I'm respiratory. Indeed.
Thank you, Laura. Amanda snacking.
I'm small. My name's Amanda. I'm the exercise physiologist.
Very good. Okay, one thing you'll notice on the agenda is announcements. We're gonna bump those to the end. Kind of something we'll talk about before we head out. Jamie's gonna chat with us really quick. Then Matt will educate us and Doc will share his story. Thank you, everybody.
Jessica got it.
Hi, everybody. I'm Jamie Bear. So I'm here in pulmonary rehab for 4 years. I've been a respiratory therapist for 27 years. I don't know how. But I was very fortunate to get to come join Alex's team 4 years ago. And it's so fun to watch patients getting better, maintaining their health, and I absolutely love that. So I'm now the American Lung Association facilitator for Better Breathers Club. So there's a few things. Number one, if you have this handout, we have some up here. We can pass them out to you. Please save these dates. We're going to have a meeting every month except for July, November, December, and January. I left all the bad air quality and the bad the really busy months out. So if you could put these on your calendar, if it's something you want to attend, that would be great. I already have a lot of speakers lined up. So in March, we're going to have Alan Wentworth from the American Lung Association, as well as Rebecca Vaughn from the lung transplant team, gonna all be here. So that'll be a they're all good, but that one will be really good as well. So please put those on your calendar, and that way you can just have them in here. So in case you miss the email or whatnot. Also, at the end today, I would like to have you all fill out a meeting evaluation form. And then down here at the bottom, it says any additional comments or suggestions for future meetings. So if there's something you're thinking, wow, I'd really like to learn more about that, Jessica and I could work on, getting you some speakers that might be interesting to you. So I'll have these at the table. But other than that, I think a lot of you have been through pulmonary rehab here. Even if, as Jessica said, if you're not a patient here, that's okay. Bring your family, bring your friends to these, because this is it's patient run, it's for your support. So, I really hope that you all will attend and bring caregivers too. I'm really glad to see caregivers here as well, because that's a huge part of it. So thank you all for being here, and I'm going to turn it over to Matt now.
Cool. Thanks, Jamie. And thank you so much for being here. Thanks for having me. I love my job. I mean, to Matt with PulmonX, I love my job for a couple reasons. One of which is the people I get to work with. So Christian is not here today, but she's my colleague that lives in Nevada. I live in Lakewood, and we cover New Mexico, Colorado, Wyoming, Montana, Utah. We're gonna have a third member here in a month's time, but large territory, but there's not a whole ton up in Wyoming or New Mexico for that matter, a lot of dirt. But it's the people I get to work with. Megan Hansford is the coordinator for this program. She's amazing. There's a ton of great RTs, nurses, docs in Colorado that we get to work with that make this experience very rewarding. And last is something that keeps me going every day. It's doc. It's testimonies like doc and patients that have gotten this procedure and their lives are changing. So those are pretty cool, and looking forward to hearing you talk here a little bit. I always get a little emotional. But is it Celeste in front here? I'm gonna pass around this valve. I wish I had more of them, and if you drop it and we lose it, it's totally okay. It's very small, but I wanted to pass that around for you to get an idea of how tiny our lung airways are and how small these valves are. Some of what I'll present here, and this is very informal, so if you have questions, please don't.
See that, Randy?
Yeah, yeah. Thank you.
Yeah, please interrupt if you have any questions, but some of what I'll say today is stuff that you all may already know, probably already know, but for some do not. And it's to learn a few things on COPD and BLVR, which is bronchoscopic lung volume reduction. So this is a procedure that was FDA approved in 2018. Before that, though, there were patients being treated in Europe. We're in 25 countries today. We're based out of Redwood City, California. I might have said that already, but it's just outside San Francisco. And then we also have a headquarters in Switzerland. But COPD is a progressive disease where you're breathless. Hyperinflation in the lungs, the diaphragm is completely squeezed down. You lose elasticity of the lung, the rubber band of the lung. And the trapped air allows you to inhale, but not properly exhale. And so that's what these patients are challenged with each and every day. You'll see healthy tissue there on the top. Patients with severe emphysema on the bottom. Too much to add on this.
Oops.
I apologize. There's a lot of.
I have to read everything.
Yeah, please.
I also have a little OCD.
I get it, and I'm happy to share this this slide deck for anyone that wants it, or with Jamie to share
I'll share it out.
with the crew.
Thank you.
Yeah, no problem. So before Zephyr valves, before Palm Rehab, which is a huge part of this, before inhalers, a few states of just how a patient feels with COPD. Shortness of breath, we mentioned some of the more common things like brushing your teeth, taking a shower. Some of these patients are challenged with things that others take for granted, but decreased activity in general, not to where you felt, years ago. And we're trying to improve all of that. This slide really drives me. So patients that are diagnosed with severe emphysema, half will pass within 5 years. That's far too high. And lung cancer is the #1 killer today. Combined, the next 3 cancers, it kills more combined than the next 3 cancers, lung cancer does. But COPD patients have a worse quality of life than stage 4 lung cancer patients. So there's a huge need to help this patient population out. And your LAMA, your inhalers, your steroids, pulmonary rehab, it's all part of the puzzle to making these patients feel better. But this is kind of the next step beyond that. Treatment options today. I mentioned LAMA and your inhalers, pulm rehab. We have a couple of transplant patients today in the room. Incredible. Oh, thank you very much. And then lung volume reduction surgery. I'll talk about this in a little bit, but we fall in the middle. So Zephyr valves, if you're not familiar what a bronchoscope looks like, this is a single-use bronchoscope. So there's a camera on a working channel. So you can insert, biopsy needles if you're going to biopsy the lung. You can insert delivery catheters if you're going to deploy valves inside the lung. But this is what a bronchoscope looks like. You go through the mouth, pretty minimally invasive. When you get to these options here, this is taking out the lung. So surgically going in and cutting out tissue or taking out the lobe that is worse than the lung, and then lung transplant. We all know what that looks like, but we're the middle ground of these options here. And we're for patients that we've exhausted the medical therapies, they're optimized medically, but still breathless. That's when we consider Zephyr valves. Does that make sense? The continuum of options there. So this is what the BLVR procedure will look like. So you'll see that bronchoscope. We're going to be treating the right upper lobe for this particular patient. And we're going to use the delivery catheter. The valves are inside the delivery catheter at this point, as you can see. And we're going to place one-way valves. So these valves are allowing air to come out, but not air to come in. What we're intentionally trying to do is get atelectasis to shrink this particular lobe so the other lobes expand and function better. Make sense? Sometimes we treat the right upper lobe and right middle lobe as a combo, but 90% of the time north of that, we're treating one of the 5 lobes of the lung. And you should see that diaphragm rise immediately post-procedure, post-X-ray. Valves placed in the lung, you'll see, I've seen anywhere from 2 to 10 based on a patient's anatomy. 10 is on the extreme high side. That was one case that I can remember in Colorado, but most of the time it's 3 to 5 valves. Doc, how many valves did you say 4. You had placed? 4. So that's in that sweet spot of 3 to 5. That's most of the time what you see. I mentioned.
Is that at one time or
Correct.
Successively? 4 at once?
That's a great question. Most of the time, 4 at once.
Okay.
There are physicians around the country. There are a couple studies, one in Belgium, one from UC Davis in California, where the patients were staged. So say 4 valves were required in the right upper lobe, 3 are placed today, and then they come back in a month for the last one to be placed.
Okay.
But mostly they're placed day of. Gold guidelines. So I mentioned 2018, we were FDA approved. In 2020, Zephyr valves, bronchoscopic lung volume procedure, was recommended in the gold guidelines, evidence level A, the highest recommended evidence. So if you have a patient with severe emphysema, this is gold evidence A, evidence A to treat your patient if they qualify for bronchoscopic lung volume reduction. 40,000, it's much higher now. It's a slightly outdated slide, but being in 25 countries today, that number is much greater. Clinical evidence, I won't bore you too much, but 2001, the NET trial, that was based on lung volume reduction surgery. So a lobectomy, it's snipping tissue away from the lung. Effective. There was some clinical evidence of being effective. However, there was a 9% mortality, 90-day mortality rate. 50% near where their air leak, persistent air leak was caused. 90% air leaks. The Zephyr valve, I'll go into this a little bit, will cause air leaks from time to time, depending on the pneumothorax. But that NET trial kind of started this whole, like, can we treat COPD differently by cutting out the worst lobe in many cases. And then 2010 to 2018, you see 6 different trials experimenting with valves. The Liberate trial, which you'll see in 2018, is the one, when published, earned us our FDA approval. But the Liberate, Transform, Impact, and Stelvio are our 4 randomized controlled trials that are most relevant. A couple other different studies on life expectancy when placing valves, and then there's also a cardiac function study as well that I'm happy to share. Information on those studies are below. I don't want to get too deep into those. Gold evidence level A, once again, you'll see all the benefits of bronchoscopic lung volume reduction and what we intend to do post-treatment. Give you a chance to read, for our lung transplant patients, if you do qualify, this is something that can buy you time, give you a better quality of life until you have that lung transplant. But it doesn't replace lung transplants sometimes, excuse me. Here's two x-rays. You'll see the one on the left, the diaphragm is a little flatter than the one on the right. Valves were placed in this patient, and you can see that diaphragm just a little bit more rounded. That's when we get back that elasticity. We're trying to reduce or remove hyperinflation. There's no medical therapies today that reduce or remove that hyperinflation that COPD patients are challenged with. So that's a good post result. And you'll see a lot of these results. There's an x-ray taken once the procedure is finished, and it's a rather efficient procedure, 35 minutes maybe on average. We'll take an x-ray directly after, and you'll see that diaphragm already up. You'll get that atelectasis, you'll get that shrinking of the lobe almost immediately sometimes.
I don't see the valves. They're that small where you can't see them.
Yeah. I mean, you saw it in your hand.
Right.
Yeah, it's near impossible. If you get super granular, like on a CT scan and really zoom in, you can see them. But x-rays, you won't.
So the procedure to put the valves in is only like 35 minutes?
Yeah, from bronch in to bronch out. Of course, anesthesia does their thing, pre and post. You're waking up, recovering. But the actual loading valves and the procedure
And it
itself
goes in
is.
through your mouth.
Yep, exactly. Megan knows this slide very well. There's a lot that goes into qualifying, and really it starts from a PFT. So residual volume is really evaluating the amount of trapped air in your lung. We need to see that over 150%. TLC is total lung capacity over 100. FEV1 between 15 and 50. Ultimately, we're trying to treat the right patients. We're trying to ensure that when you're at the table, that you're going to benefit from this valve procedure. So there's a lot of things that we check the box with to ensure that. BMI is not super important of 35. It is required that you non-smoking for 4 months prior to the procedure and a commitment to stop post. It would not help the valve performance if a patient were to continue smoking post procedure. And then a 6-minute walk distance between 100 and 500 meters. So not necessarily wheelchair bound, but also you're not moving super well. You're not going to benefit extremely well. If you're doing, if you're moving a lot of distance in a short amount of time, I don't know how much impact valves will give you at this time. So 6-minute walk distance is a good one. We take a CT scan. If all these parameters fit the bill, we take a PFT scan and we send it. I know this is super small. For those virtual can probably see it pretty well, but very small for those in person. So a CT scan is taken, and that CT scan is uploaded to a website that produces a StratX report. And what this StratX report tells Megan, tells Dr. Parrish, the interventional pulmonologist here at Anschutz, tells you how complete your fissures are, which are, they divide and sort of complete the lobe inside the lung. The voxel density, that's just the destruction. So the amount of emphysema you have in your lungs. And then inspiratory volume, that's the amount of trapped air in all 5 lobes. So this can guide you where to treat. For those in the room, or for those virtual, will see it easily, but in this case, the right lower lobe has the highest number of voxel density. That could be a target for this particular patient. To place valve in the right lower lobe, we take down the right lower lobe so other lobes expand, function better, breathe better. The neat thing too that I should have mentioned in the treatment care options is this is a reversible procedure. If you don't respond well, you can remove the valves quite easy. If you do a lobectomy, if you take out lung tissue, that's not reversible, right? The LVR is. But that's called a StratX report, and it further guides us on treatment options and what lobe to target in the procedure. Am I doing okay on time? Half an hour?
you're, yeah.
Okay, cool. Let's speak about collateral ventilation. So I thought of this analogy last weekend. Let's say in your apartment, your condo, your home right now, your back screen door cannot close. And you do not have a furnace, but you want a warm home. You're not going to install a furnace until you get that screen door fixed, right? Collateral ventilation, my new analogy, works like that for me. So before we place valves in the lung, we're going to do what's called a Chartis assessment, where we go to that particular lobe and we see if there's air flowing. So let's say, for example, left upper lobe is the lobe that we're targeting. We're going to go deploy a balloon in the left upper lobe to see if there's air bypassing to your other side, your left lower lobe. If there is, placing valves in the front side will do nothing for you. So you're going to have to pass this test, which can only be done endobronchially through this balloon. We'll do a Chartis assessment first and foremost to measure collateral ventilation, closing that screen door so you can put that furnace in to heat your home. Does that make sense? That concept? So this procedure, or this just quick assessment, takes anywhere from 2 to 5 minutes. Data shows in the field 1 of 10 patients will be CV positive, meaning there is air bypassing between the lobes. Smoking, radon exposure, that does nothing to your fissures. It's all genetic. So this is a test also. I went back to, I was showing you the STRATEX report, looking at fissures. We are not taking any patients to table below 80. So looking for 80 plus. And some physicians might even want 85, 90 plus. But basically ensuring that we'll have a better chance at being collateral ventilation negative. Does that make sense? Kind of a new concept for most. It was for me when I started. But is there air bypassing in between the lobes? That's what we're answering. And this is what the Chartis assessment looks like. So it's just a computer that's bedside. And we have a balloon and a catheter that connects to this system. So just like your gas is measuring how much fuel is going into your car, this is measuring the air coming out, coming in. And here's a nice visual. So here's the balloon through the working channel of the bronchoscope. Looks like we're treating the right upper lobe in this case. We're deploying this balloon to cover the entire lobe. And then we want to ensure that there's no air bypassing off the backside. It's yet another box check of making sure that the right patients are treated, and that gives you the best chance to benefit as well. This is a nice video to show you exactly what our lungs look like and what these valves look like inside the lung. And you'll see a valve here deployed. These are made of silicone and nitinol. Nitinol with heat, which inside the body, all of our bodies are warm, becomes more flexible. Nitinol is made of titanium. You can see that silicone opening. That's the air escaping out. No air is getting in. One way.
Still looks like it was put in and then it opens up.
Yeah. Yeah, because I'll show you the delivery catheter. So the bronchoscope is pretty darn small to begin with, right? I'll show you this delivery catheter, what it looks like. And you saw the valve in your hand. These are very, very small. So they're inside this delivery catheter.
Oh, wow. Okay.
Yeah. And then they're going to expand out once deployed.
If they're not working, then how do they get it small again to take it out?
If they're not working, how do they get? Oh, you just grab a forceps and you'll grab the valve by the frame and pull out. Yep. Yep. There are cases where there's granulation tissue that is created from your body just fighting a foreign body. That's normal. Sometimes we have to fight, get rid of that granulation tissue first before grabbing the valve to remove it. However, most times removing is pretty simple. So the biggest consequence of this procedure, there's risk to any procedure, but the biggest consequence is a pneumothorax. Has everyone heard that term? Anyone? 5 minutes. Thank you so much. So patients are admitted for 3 nights post-procedure. Did you have a pneumo post-procedure?
No.
No. Data shows us north of 30% of patients get a pneumothorax post-procedure. Let's take a patient that your left upper lobe is treated. When we're taking down that left upper lobe with valves, the left lower is going to get that air almost immediately, usually immediately, and it's going to expand. That's what we're trying to do. When we're expanding that left lower lobe in this case, it's possible that lobe tears. And when it tears, you could have a pneumothorax. It's a consequence of the procedure. Patients that had a pneumo post-procedure actually did marginally better than those that did not. Do you want a pneumo? Absolutely not. But your provider, your Megan Hansfords of the world, will set those expectations that this is a possibility. And it'll be taken serious. You'll be admitted in the hospital for a little longer than 3 nights, but all of our patients are admitted 3 nights post-procedure to monitor for pneumothoraxes. In the field, it's closer to 1 of 5 patients will receive a pneumo. And then your physician will treat that pneumo, and you'll get out of the hospital and hopefully feel much better than you did before you came in. A couple more for you. MRI conditional, so you'll get a card after you're treated, but these are MRI conditional, these valves. And this is what we're looking for, right? At the end of the day, this is a quality of life procedure. We're hoping that you can play with your grandkids post-procedure. We're hoping you can take your shower better, all the little things that we all take for granted. We're just hoping that you feel even better than you did before, right? So ultimately, though, we're reducing and removing the hyperinflation in your lungs, the trapped air that was giving you the issues to begin with. Thank you. Any questions? Go ahead. I know we have a couple minutes before Doc goes.
Now,
Yeah.
can you go through airport scanners with this in
Yeah.
without it setting it off?
Yeah, and that's what's
Okay.
MR conditional.
Oh, okay.
Yep, MRI conditional.
Okay.
Does that
Absolutely,
mean
good
you
question.
Go through an MRI, that's what I mean.
Yep.
Okay, gotcha.
But
Yeah.
airport scanner, security scanner, absolutely, yeah. You won't. Please go ahead. So a severe emphysema diagnosis, and then it really starts with the PFT. So the pulmonary function tests on the top left, if you fit that parameters, half the time you will qualify for this procedure. But high level, this procedure is you're optimized medically with medical therapies, pulmonary rehab is part of your picture, and you're still breathless. That's when we go here to consider this. Please.
Are there any medications that you have to take after the procedure is done?
No, nothing specific relative to this procedure. Expectations are always a good thing to communicate pre and post. Pre, the expectation, I'm curious, your conversation, Doc, with Dr. Lusani, but the expectation should be nothing will change, right? We don't want to promise anything. We don't want to promise that you get off oxygen, because that's real. Is there possibilities of you getting off oxygen? Yes, but it's never anything to expect.
So I don't see the oxygen level up here. I was turned down because I'm on 12 to 15 to walk.
Okay.
So what is the threshold for how much oxygen you're on qualification?
It's by discretion, physician discretion. Megan, do you know what the program is? A tough one.
I don't know. I was just wondering if maybe your blood gas had some other value to that, made you not a candidate, but.
Yeah, they just look at it for the oxygen.
Yeah,
But I mean, there's
That's
other contraindications too.
Yeah.
That sometimes people might not be chosen for.
yes.
So the oxygen may have been part of it, Reggie, but it might have been.
Oh, that was the reason
something
they
too that wasn't necessary. But it is a procedure. Like you're going in.
General anesthesia going under. But yeah, that's a great point.
Yes, I just wondered if there was a certain level that they look at, but if it's not okay.
I'll find out for you. That's a great question. And
Sure, PaO2 is really low on room air when you do your.
Oh, yeah, rule out severe hypoxemia, less than 40, yeah. Could be that. No, I see it's 15 to 50%.
yes,
Mine says 66%.
okay.
So would I fit in that category?
You would not. However, that's why you follow up with your pulmonologist, maybe on a yearly basis. With this being a progressive disease. You know,
I'm going the other way. One of the, I guess, fortunate ones.
It's awesome.
I use less oxygen now than I did 4 years ago.
It's amazing. Keep it rolling. Yeah, that's great. And pulm rehab. It's recommended to be in here prior to BLVR, but required post. I mean, you're in here to get stronger, and it certainly works in conjunction with valves. You need to be a motivated patient. Thank you, everyone. If anyone doesn't have any questions, I'll kick it off to Doc. Thanks, Andy.
Doc, come here. Would you like your phone or you have a loud voice?
Well, sometimes.
Would you like a microphone?
Sure.
Yeah.
Probably can't.
Testing. Okay.
Okay. How to vote Doc Davis. And let's see, I'll start at the beginning, right? I was diagnosed with COPD in 2020. And then not too long after that, the next year, RA, or maybe shorter than that. So that already was an issue to deal with. But in 2023, we went on vacation in Utah. And we were in a dust storm. And the dust storm, I didn't think a whole lot of it at the time. But it really did a number on me. It nearly put me under. When I say that, I felt pretty bad, but we got to a campsite and I just said, I've got to get home. So I lifted on back to Denver. And I was just flat on my back, just feeling awful. But I thought, well, I'm going to get better. I thought, deny myself into believing that. But wasn't too long after that well, I had a all out respiratory failure, and in the middle of the night we decided I better get to emergency. We got to we went to Lutheran, or it doesn't matter. We got to the VA. I'm a native veteran, and we got to the VA, and my oxygen level was 20. and my blood pressure or my heart rate was 170. So they were just like, we don't even know why you're living. But anyway, so I was in intensive care for a week because they had to run all kinds of tests because they were worried about valley fever, and what that is coccyx. There's all kinds of things in the desert soil. And when it gets riled up, if you breathe that in, you could be severely affected. And I was. Well, I didn't have any of that, those things to worry about. But like I said, I had a severe respiratory failure, which is enough to deal with. So I got home and I felt like I was about 100 years old. Couldn't get off the couch, couldn't get off, just couldn't do anything but sleep. But little by little, I pushed myself. I should preface this, I swam for over 20 years and I worked with special needs guys. So I was always working out. But what happened was I could not make it anywhere. I couldn't get off the sofa, then out to the front steps, then out to the fence, and eventually down the street, and worked on it. All the time I'm looking for pulmonary rehab exercises online, and I came across this procedure and I thought, geez, this could be the answer, But there's a lot of tests you had to pass, and I kept working at it and kept doing it until somebody listened to me, and I was referred to Dr. Masani at UCH. And all the time I'm doing this, I'm a musician. I play several instruments, and one of them is a harmonica. And I played in the Navy and, just been playing all my life. And so I kept working at it and I could not breathe at all. But working at it. Harmonica is one of the best instruments you can ever come across. And the reason why is because it works the diaphragm. You breathe in, you blow out, you breathe in, you blow out. That's natural. Anybody can do that. So I just said, okay, I'm starting right here, right with that. And kept at it and got the procedure done in 2024. First, they tried to do it in January of that year. And what had happened in intensive care is they hit me so hard with all this albuterol, which is a good thing, but you can OD on it. And it caused my heart to go into AFib. So not only have to deal with the lungs, but now I got to deal with the heart, which I never had any problems with. But so that was interesting. But kept pushing it. And then they rescheduled it in June of 2024. And that was successful. First day, I'm under anesthesia for an hour. Come out of that, and first thing I thought was, feel better. I can't really put my finger on it because it felt like somebody had already punched me. And but by the next day, I could really notice a difference in it right away. So going into this procedure, I had to use 6 liters of oxygen. Coming out of it, I was on 4. Push, exercise twice a week at pulmonary rehab, but every day on my own. You got to really be proactive if you want to make it. You got a choice every day. You can get up and die, or you can get up off the couch. So push. And now I'm doing things 3, sometimes 4 liters, but a lot on 2. We went to the Great Lakes a couple times this last year, and I hardly needed any oxygen at all. So, does it work? I'd say yeah. And, you know, look at all the videos and do your homework, do your exercises all the time, and you'll be successful with it. I would recommend it to anybody.
Good for you.
There you go.
Yeah, that's a question.
Yes, sir. Yes.
After you had the valves put in
Mhm.
and notice your oxygen got better, is because you live in Colorado, why you have oxygen now?
You know, that's a good question, and I can answer that from my own experience. At the Great Lakes, I used like 1 liter. Here, it's double that at the very least. I mean, if I'm sitting, I can do it on 2. If I'm moving around, it's 3 or 4. And we went to the Great Lakes this last time and came home, and it's a struggle because you're starting again. So I would say elevation makes a big difference.
If I could add, there's a great press release on Doc's story. UC published it in October of 2024.
Yeah.
Cool.
And you're certainly welcome to check it out. It's on the patient portal. Check it out, see it. You can even see my singing dog. My dog likes to sing to my harmonica, so we start the day every day on the back deck doing the harmonica, and he's wailing. I am, we're called the Huff and Puffers, but the leader retired about a month or so ago. So I tried to bring people, okay, I tried to bring people back, but it didn't work. But as I understand, they have the harmonic cats here, and I'm going to be checking that out and see if I can do that. So, yeah, you don't have to know how to read music, but there is a lot of harmonica lessons online. Some great teachers. And like I say, you don't really have to know anything about music. I know how to read music, but I'm not so fast at it. I got an ear. I got a great ear, and I've been playing one thing after another all my life. I'm a guitar player, piano. I was a drummer in school. So, you know. Anybody else? Any other questions? Curiosities? So you guys are going to get signed up for it, right? All righty.
Thank you.
Thank you for having me.
Thank you very much. Hey, I'm gonna pull up, it'll take me a moment, but I did want to just pull up American Lungs website so we can show you some upcoming events that they do have. You can talk amongst yourselves for a minute, it'll be a minute. Yes, right there. Thank you so much. That's a great idea. Thank you, thank you.
Yeah, no, I'm like, yeah, they put on like. So I just said, you know, this is I have to, you know, use this a lot, you know. Can't even just do that.
So if you guys haven't checked this out, it's the Patient and Caregiver Network online. They have so many amazing resources. They have the Wellness Hub. You can link in with certain different disease-specific online communities, webcasts, management tools, just all kind advocacy information. So it's a really good free network for everyone. You want to talk about any events coming up, Jessica?
Yeah,
Have at
a
it.
couple of quick announcements and we'll get everybody out of here close to on time. Thank you again, Matt.
That was great.
Really good. I don't know if it was the same for everybody else, but Doc, you made me emotional sharing your story. It's just kind of a reminder of like how much we go through to just even show up here. And so I want to thank everybody for doing that. And I think I got to put on a t-shirt, Doc said you have a choice every day. You can get up and die or you can get up off the couch. And it's like, I need a t-shirt that says that. Yes. Absolutely. Absolutely. So a couple of upcoming events. The American Lung Association has their fundraising gala actually this Saturday night. I'm excited. It's a Roaring 20s theme. So it should be fun. If I don't see you all there, I'll tell you about it at next month's meeting. And then our next meeting here is the 31st. Jamie mentioned Alan is coming. One of my favorite topics is about air quality. I'm one of those people who checks it before I see if I'm leaving my house that day. And so he just gives a really thorough report of what that looks like, how they like the particles in the air and what makes a bad air day, those kind of things. And then we also have Rebecca coming, who's the social worker. So kind of get a 2-for-1 next month. American Lung Association, and this is also on their website, is doing a Fight for Air climb at Coors Field in April. You can walk it or you can run it, or you can be like me and just volunteer and watch everybody else do their thing. Yes. It looks fun. What's it called? The Fight for Air climb, and that's April 25th at Coors Field. Yes.
Run the stands and up and down the stairs or the lower bowl.
Or you could walk them.
So yeah,
Of course. Or you can walk.
yeah.
You can do whatever. It's
And you see like fire department people there, like in their full gear, getting their lungs stronger too. It's pretty cool. Yeah. Did I miss anything?
Mark your calendars, Moving Mountains, which is a patient-centered, patient run, once again, conference. That'll be September 12th. But that's a ways away, but just get it in your calendar now.
Another awesome event.
It did. That's right. It's going to be in Highlands Ranch. It's the brand new Highlands Ranch Rec Center. So yeah. So September 12th. And it's a senior center parking right there. It's supposed to be a really nice venue. So I'm excited to check that out.
And then a reminder, Harmonicats, Tuesdays here, 11 to 12 o'clock. I think we covered everything. Passed around the meeting evaluation. If you didn't get a bun cake, please grab one. Please make sure you're signed up so we can make sure we're getting you the information for every month's meeting. And were there any questions?